medically from the beginning. Oh, sorry. Wow. And so I think it's important for things like that. There's also fairly common infections in the uterus that happen after delivery that can lead to sepsis and death. I saw when I was a resident, a patient come into the emergency room. She was immediately put into the elevator to go upstairs to go to the emergency room or go to the operating room for an emergency surgery, and she died on the way up there because she developed sepsis. Within 24 hours, she was dead. And so these are the more common things than suicide rates or cancer rates or anything like that that happen to moms that can cause problems with them being able to take care of their child appropriately. And so, again, the best way to support the baby is to support the mom. And most of the things that I've just mentioned occur within the first year. I'll give another example. I went to a leadership thing last night that said that people remember stories better. And so there's a story of a woman who we recently delivered here 11 weeks ago. So she's outside of that 60-day window, who went into the emergency room this weekend with a severe pulmonary embolus, a clot in her lung that could have killed her and luckily did not. But during the workup for that, they also found problems with her heart, and she had studies done that show that her heart is working less than 30% than what it should be. And that damage was caused by the pregnancy. So pregnancy is not a benign thing all the time, even though most patients do fine. And so this woman now has a very severely damaged heart because she was pregnant twice and had these complications. And that would be something that's probably a $50,000 workup that she's going through with treatment. And if she was not still on Medicaid, she would not be able to afford that and could pass away. So there are catastrophic things that happen. There are common things that happen. And most moms who are on Medicaid, who then, when that lapses, they don't have the medical care. They don't have the ability to be able to go in and see the doctor and pay for that and pay for the medications they might need if something happens. And then, therefore, they're not able to take care of their child appropriately.
All right. So we'll go into questions. Let me just start with a couple. And so we're talking about this 1 year window, right, from 60 days to 1 year. And I think the committee would be really interested, and information would be helpful. What does it look like? How often do people come in with complications? 3 months, 6 months, 9 months out? There's certainly all sorts of encouragements to go get checks while you're pregnant. Is there anything after the fact that says you really should come in for a 30-day check-in 6 months after giving birth? Is there any kind of standardized medical, encouragement on that?
Yes, thank you, Chairman Zwanzer. Yes, so the standard for prenatal care and postpartum care is that in someone who has a routine vaginal delivery, we see them back at 6 weeks, which is 42 days after delivery. And the majority of people are able to get in and do that, and we do encourage that. Some patients are not able to. There are circumstances where, if they're back to work or, especially in some of these vulnerable populations, they're not able to stay home for the full 6 weeks and they may be back to work and it's difficult to get in. And so sometimes it is difficult to get them in within that window. Medicaid also has several rules. And one of those rules is that we can't place long-term birth control at the time of their postpartum appointment. They won't pay for it if we place it during that postpartum appointment. And so then we have to make a separate appointment for them to have some kind of birth control. If a patient decides not to do a long-acting birth control method, then we are only allowed, based on pharmacy rules, to give out a 3-month prescription for birth control. And they have to get refills after that. So if they get the prescription even within that 60-day window, after 3 months, they would have to go back and get another prescription, and that would not be paid for. And so definitely there are prescribed things, and the routine postpartum visit does fall within that 60-day window. But if we find complications at that time, then many times we're not able to do that. Things like tubal ligations. If somebody wants permanent birth control, it's difficult to get them scheduled because we wait for that 6 weeks, and then we have to get them scheduled after that. And so a lot of times they are not able to, leads to, unintended pregnancies. And we know the current abortion issue at the moment. And so it's a rolling downhill snowball collecting.
Other questions, committee? Representative Penn.
You mentioned the potential complications after, in the postpartum period. Are you able to provide us with any statistics on what the likelihood would be of a postpartum uterine infection or mastitis, or especially, do you have any statistics on what the likelihood would be of the heart issue that you discussed?
Dr. Hinkle, if you have those with you, or do you know?
Representative Penn, Chairman, I don't have those statistics on hand. I can tell you my experience is many of these things are rare. The heart issue is rare. I currently have 2 patients that delivered in the last 2 years that have had an issue just very similar to this. So it's not common, but they're catastrophic when they do occur. And I think that's the same with some of the other things that were talked about yesterday, the cancer rates. I was involved in a case where a patient came in 8 months after delivery and ended up with stage 4 breast cancer that was not found on multiple visits and multiple things. So those things do happen, but they do happen rarely. I don't necessarily have a particular statistic. The things like endometrial or uterine infections. Uterine infections happen probably less than 10% of the time. We do things to try and prevent that. We do antibiotics beforehand. We do, especially when we do surgeries, we do antibiotics for group beta strep, which is a common bacteria that has decreased our uterine infection rates, but they still happen. The problem is that, again, when they happen, they can be catastrophic. Mastitis is probably about 10% of the population.
Okay. Real quick, do you do any of the postpartum depression counseling, or does that generally go to behavioral health, or does that come into your office and in your realm as well?
Chairman Wanitzer, yeah, I think half my job is being a counselor, so we do a lot of that. And we do see postpartum depression in quite a few patients, and most of the time it is controllable, it is treatable, and patients do fairly well. Probably about half of the patients we see with postpartum depression do great, even without medications. They can do counseling. We do screen for every patient that comes in at their 6-week postpartum. So if we get them to come in for that appointment that we recommended, we do a screening at that time. And the pediatricians also, when they bring their babies in for routine pediatric appointments, the pediatricians are also doing a screen of the mom as well, because again, baby's care is dependent typically on the mom, and so making sure the mom is doing well.
Can I just throw one more question at you then? So if someone gets a medication prescription, then for how long would a normal regime be? Is it a 2 month? Is it 6 months?
Chairman Wanitzer, we say at least 6 months to a year. And postpartum depression can be diagnosed up to a year after delivery.
Further questions down here? Representative Chadwick.
Thank you, Mr. Chairman. Dr. Hinkle, given that you're a provider and that Medicaid routinely underpays, that leaves you and your fellow providers carrying a rather large burden quite often. Could you expand on that for us and what your thoughts are? How do you balance that out?
Chairman Wanitzer, Representative Chadwick. Yes, we do get about a third of what we typically charge for prenatal care and delivery. So we get one fee. So we see patients on average 12 to 14 times during their pregnancy, and then do the delivery and then see them for a postpartum check. And for all of those visits, we get one fee. And that fee that we get from Medicaid is about a third of what we charge a routine Blue Cross Blue Shield of Wyoming, for example. We have approximately 30% of our patients are Medicaid. And so it is part of our business model that you have to build in, because we have to take care of those patients. I mean, there's not anybody to take care of them if we don't see them. And so it is a known thing, and it can be a burden. Wyoming pays better, Medicaid, Wyoming pays better than many other states. I have friends in Florida who make $900 for all of those things, and we get about double that. So, we are burdened, but it's not overly. Medicaid right now is withholding money from us if our patients don't come back for that 6-week visit, because they want to try and encourage patients. And so they're making the providers pay for that, basically, if we don't get them to come back in. So there are some burdens that we're working through at the moment. We see patients not come back for that 6-week visit for, again, the things I talked about. They're having to go back to work. They're not sure it's going to be covered, and they don't have the knowledge. And so we work with our nurses and try and contact them and do all those things. What we see is, there are a certain percentage of patients who, because they don't come in and get their birth control, they come back in pregnant within the next year. And that's something that we as providers feel is unsafe. We like to wait at least a year before somebody gets pregnant. And so we encourage patients to wait those times. So it's a huge number of things. It's not one particular thing that is the burden.
Good enough, Representative Chadwick? Okay. Representative Ward? Thank you.
Yes, thank you, Chairman. And perhaps the good doctor would not like to answer this question, but she did bring up pro-life, so I'm curious if she performs abortions. I don't think that we should continue to use pro-life as a justification to expand entitlement programs, and that's the reason for my question.
And so I'm just making sure, Representative Ward, it's on the bill. And so if you can tell me that it's a question that relates to the bill, I'm more than happy to take it, but is that relation to the bill?
I withdraw my question.
Okay. Any other questions for Dr. Hinkle in regards to House Bill 4? Representative Penn?
Thank you, Chairman. I would like to ask, with regards to long-term birth control, you said that Medicaid prevents you from being able to administer or implement long-term birth controls at 6-week postpartum follow-up. So with that, I have a couple of questions. One, do other, like private insurance payers, do they allow it at a 6-week postpartum visit? And would then, so if a Medicaid patient is unable to get it at their 6-week postpartum visit, is it true that they would still then have, under the current coverage, 2 weeks to follow up and still receive that?
Dr. Hinkle, if you know.
Chairman's one answer, Representative Penn. Yes, it's mixed. So Medicaid does not allow the long-term birth control to be, that visit to be included in the postpartum visit. And typically TRICARE follows that. So TRICARE patients would be the same way. Some private insurances do allow that to be done. And it's not the visit that we're getting paid for. So if we do a postpartum visit and place an IUD or an Nexplanon in somebody, we don't charge extra for that placement, but we actually, we buy our group, we buy the IUDs or the Nexplanons, which are over $1,000, and place them. And if you place them at a postpartum visit for Medicaid or TRICARE, they're not covered. They won't pay for the actual device. And so that's why we can't afford as a practice to lose $1,000 every time we place one of those. There's also been a push, just as an aside, there's also been a push to try and place these long-term birth control methods at the time of delivery or before they leave the hospital. We also cannot get that passed through because Medicaid won't pay for the device through the hospital. And so those are some of our issues with long-term birth control. Some of the private insurers will pay at the time of the visit. As far as they do have up to 2 weeks to get in, then with the 60 days. But again, many of them by this time are working or they're, difficult schedules. And we as OBGYNs are, very busy, and sometimes their schedule doesn't allow. So yes, they do have up to 2 weeks to schedule it, but sometimes that's not enough time.
No? Further questions for Dr. Hinkle? You have another one? Follow up, yeah? Yep, go ahead, Representative Penn.
Thank you, Representative, or Chairman. Still learning this. Okay. So you mentioned just now that there's beginning to be a push to try to institute those long-term birth control methods before they leave the hospital. Is that becoming a fairly common practice? And then I would be interested to know on that, are other private insurances and things allowing for payment of that?
Dr. Hinkle, go ahead.
Chairman's answer, Representative Penn. We have not found a way to have the devices paid for when they're done at the hospital. So we'd have to somehow get a device from somewhere else, and we can't supply them from our office into the hospital and have them be paid for. So it is a payment issue. And if it was, $30, I think we'd all be fine. But since it's $1,000 a shot, we're not okay with that. There is a push, many, especially kind of inner city hospitals that see more vulnerable populations to try and get the long-term birth controls in early.
So then in relation to this bill, if we extended that Medicaid coverage, would that allow payment in those cases?
It doesn't allow, I'm sorry.
It's not a
Chairman's
Medicaid
answer,
issue.
It
Go
doesn't
ahead.
allow payment for that at that time.
All right, knowing you have to get out of here, thank you very much,
Okay.
Dr. Hinkle, for being here.
Thank you.
Yep. Public comment? I wasn't sure if you were escorting or, wow. Welcome.
Chairman Zwanser and members of the committee, my name is Erin McKinney, and I am the Clinical Director of Women and Children's Services at Cheyenne Regional. So I've worked along Dr. Hinkle for almost 22 years. My specialty has been in labor and delivery and women's health this entire time. So I'm here to educate, and in my role, not to go one way or another, but I just want to talk with you about, as what Dr. Hinkle said, what we see, but also the focus on work that is being done in the legislature on plans of safe care with women that are using substances during pregnancy with mental health. And so I did bring, United States has the highest level of maternal mortality than any other developed country. And so that's a lot. We have so many resources here in the United States to be able to help support our women, but it still continues to rise. One of the, what we have found with all of the review is that 2/3 of the deaths are preventable. And this isn't from pregnancy to, this is pregnancy all the way through the 365 days post-delivery. And so as Dr. Hinkle talked about, there's also the chronic illnesses that come up that patients have with diabetes, chronic hypertension, not being covered then. With how these cases are identified as maternal mortality, there's epidemiologists that do review. There's a maternal mortality committee that recently started in the state of Wyoming, which is new to us. So there are opportunities that we at some point will be able to see what those recommendations are. But from a global standpoint with the United States, a big one is substance use, mental health, and one that is not often talked about is domestic partner violence, where these would be identified if there was opportunities for the woman to be seen in the clinic, where they might, someone is laying eyes on them and noticing that there might be something else going on. As Dr. Hinkle said, most of her, time is in counseling. A lot of that happens in healthcare with taking the time to learn more about our patients and find out what the gaps are, identify biases and judgments that come into the care that we have so we can provide the best care to our patients. I think it's also important to know that based on locations, rural areas are 24, there's 24 deaths per 100,000 deliveries. And so Wyoming, that's what we are, considered pioneer. And we also have lost some services, OB services here in the state at some of the hospitals. So at least 1 in 10 women experience postpartum depression. I was one of those 1 in 10, and was able to, have the support through my physician throughout the time, and I'm sharing that as a personal experience. So when 1 in 10 is identified in that, if a mom, potentially there's a mom that's using, that's being treated for depression, her Medicaid runs out, so she then loses her coverage, and the likelihood of suicide increases dramatically. That's another common cause of maternal mortality in the United States. The other is when I talked about plans of safe care with substance use, and the last year when I did come to give education about the federal government requiring states since 2016 to implement plans of safe care, part of that work is supporting our moms with best practices in substance use. So if a mom is going through medication assistant treatment during her pregnancy and loses that treatment at 60 days, her likelihood of relapse is significantly higher. And if she was using at a high rate prior to pregnancy stops and then begins using again, her likelihood of overdosing increases. So there are opportunities with Medicaid and our moms to support them during that brief time and during that pregnancy with their substance use. But then after that runs out, there's a high risk of overdosing, relapse, child abuse. And we know that healthy moms have healthy babies. And I think that's important for all of us to know. I wanted to just say on behalf of our Cheyenne Regional Lactation Team, something that was a really big win that our lactation team worked with Medicaid was reimbursement for breast pumps for our moms. And this was a statewide collaboration with Medicaid and Healthy Babies, Healthy Moms. So we have an opportunity to improve maternal health in that way. And that is having our moms being able to pump while they're at work and having, up to 12 months and the benefits of that to decrease breast cancer, ovarian cancer, and if they choose to breastfeed, continue the longevity of that.
Question.
Stand for questions. Thank
Questions
you.
from Ms. McKinney? Representative Trujillo?
Good morning.
Good morning.
Do you happen to know about Wyoming's family planning waiver program?
I would have to rely on that. I'm aware of it, but I can't speak to it.
Okay.
I'd have to rely on other.
I'll get somebody in the room who does.
Thank you.
But do you have any other questions?
Nope, that's all.
I do have one, Ms. McKinney, that chart in front of you, because I keep hearing this statistic on developed countries. Does it say
Yes.
how many developed countries? There's lots of statistics, if there's 10 or there's 20 or there's 87 in the
Sure, it
world.
depends on where you go, yeah.
Yeah, does that, the graph or
So-
chart,
So not this one, I can provide that
or if anybody
at a
else
later
knows
time. If anybody in the back
that
can pull
statistic
that up.
on
Yeah.
we're the worst among 10 or the worst among 100, that would be good. Other questions? Representative Hornock?
Thank you, Mr. Chairman. Just a follow-up on, you mentioned the statistic that 24 in 100,000 births result in death of the mother. Did I get that statistic right?
In a rural area, it increases, it could be 24% of the women living in rural areas who have a pregnancy-related death within 365 days of delivery. Yes.
Follow up, Representative Hornock?
Yeah, Chairman. So I'm not sure how that works out for Wyoming. It seems like we're dealing with a 1,200, the number that's been thrown around is 1,200 births per year, or I could be wrong about that, but so roughly 3 to 4 in Wyoming, I suppose. Now, does that happen typically during the first 2 months, or is that something is that when it's most prevalent?
Ms. McKinney, if you know, or on your experience?
Yes. So in my experience, Cheyenne Regional alone delivers 1,000 babies. In 2020, we had 1,019 babies. And so would have to look and see what the number is. Cheyenne Regional as well as Casper are the #1 delivering hospitals in terms of number of babies, births that occur. So it would be, and like I said, there's a maternal mortality review committee that is funded by the CDC. Wyoming is a little bit later at getting into that, but there was a lot of work by several folks in our Department of Health, CDC, several people in our state who have worked towards that. And so we, like I said, we'll be finding out what that number is, but yes, it would be 2 to 3.
Okay. Further questions? Representative Penn.
Thank you, Chairman. I would just like to ask, you mentioned breastfeeding and pumping. In your experience, or if you have any statistics, in what period postpartum do women experience the most difficulties with breastfeeding and pumping issues?
Ms. McKinney.
That is Representative Penn, that is a interesting, and Chairman, thank you. I'm learning too. We know that the very beginning of postpartum is the time where moms and babies, especially first-time moms, are learning, and babies are learning how to breastfeed. So those are more of the acute situations that we see. Birth weight goes down, depending on how the feeding is going, mom's milk supply. Babies have a risk of hyperbilirubinemia, which is the jaundice babies, if they're not getting enough breast milk, especially in that first week. So in terms of what I can tell you is at Cheyenne Regional, we have a lactation team, as I mentioned before, that'll see our moms all the way up through their entire time that they're choosing to breastfeed or pump. And that is a service that we offer. We don't charge our patients for that, often because moms don't have the coverage after the fact. And so we want to make sure we're providing the best service to our moms. So those complications, the complications come when moms go back to work, if they have to, or whatever their postpartum time is, where mastitis, decreased milk supply, and how we can best support to keep moms on their goals. So, and mastitis can happen at any time. And I have seen women who have come in several months postpartum that have mastitis, and it can be detrimental, of course, to mom and the sepsis that can happen, as well as to the baby. And we know that moms are healthy, babies are healthy.
Okay, further questions for Ms. McKinney? Seeing none,
Thank you.
thank you very much, Aaron, for being here. Anyone else in Deacon? Come on down. And I'm fairly certain if you're here for our third bill today, we're not going to get to it at this point. I'm just guessing Ms. Chambers. We may still get to the second bill on our list. Welcome, Mike.
Thank you, Mr. Chairman, members of the committee. My name is Mike Lehman. I represent the Diocese of Cheyenne, which represents the Catholics around the state of Wyoming, here to speak this morning in favor of House Bill 4. To be clear, individual Catholics in the state span the entirety of the political spectrum. As an institution, however, we're nonpartisan. As I listen to comments Wednesday morning, I asked myself, what's the one thing I wish both my friends on the left and the right might take to heart when considering this question? One thing I thought I would want my friends to the left to understand is how inconsistent it feels when the state is asked to help one vulnerable segment of the population, while simultaneously saying that the intentional destruction of another segment of the population is none of the state's business. Currently, our Wyoming statutes hold many places where the state claims authority to take action according to what is deemed, quote, in the best interest of a child, unquote, while simultaneously turning a blind eye to the violence of abortion, which intentionally takes the life of children. As I've said many times in this room before this particular committee, if being human and alive aren't enough to qualify for full legal protection of the state, what else is necessary? Who gets to decide, and based upon what premise? I've yet to have anyone attempt to answer those questions in committee. I believe we'll be far more successful convincing our neighbors of our responsibility to take care of all people the moment we stop excusing the destruction of some people. So what would I want my friends on the right to take to heart on this issue? Some slopes, I guess, are more slippery than others. Not every government program is an inevitable slide into the fiery pit of socialism. We need to recognize when our colleagues are manipulating our fears that is such the case. The legislature puts side rails on laws to prevent such slides all the time. And I imagine with the great minds in this committee, if it's deemed necessary with this bill, that that's also possible. It is important to distinguish between access to health care and what is often unfairly constituted as all welfare programs. We're talking about a segment of the population that qualifies for Medicaid coverage while pregnant. And then, when the mother and child are still extremely vulnerable, they no longer qualify. We can't accept pitting one vulnerable population against another. We need to work together to help babies and moms. I was born and raised in Douglas, Wyoming. I know Wyoming people, and I know Wyoming women. In fact, at work and at home, I'm surrounded by them, which is a blessing. Women are tough. Wyoming women are tough. They don't sit at home scheming up plans and ways to go spend more of their free time in a doctor's office. If anything, they spend the early onset of their illnesses in denial. My wife is fond of saying when she's very sick, I'm fine. And I know better than to say it, but I want to say, well, you kind of sound like you're dying, so there's that. They don't want to go to a doctor. Then throw in a sudden life change like a new baby, not sleeping well, having trouble adjusting. The last thing they want to do is go to the doctor's office. And so the argument that this extension will suddenly create an overwhelming influx of moms who were qualified to overwhelm the doctor's office, it just doesn't hold much water in my opinion. The second thing I would like to remind my right-leaning friends to think about is we know the best institution to care for the rights of children is the family. That's the most basic institution. And while there are many factors that are threatening that shield of the family today, sickness and death will always be one of those factors, unfortunately. That's just a fact of life. But it becomes tragic when those illnesses are preventable and curable. It's tragic when access to prevention and cure are accessible to one, but not another. Finally, Mr. Chairman, I will close just by mentioning I received a phone call from Adam Schwend, who is the regional director of Susan B. Anthony Pro-Life America. And he expressed that their group has, and they've been a proven resource when it comes to supporting pro-life laws in Wyoming. And he told me that they fully support HB4 because they believe it is consistent with their mission of both making abortion illegal and unthinkable. Mr. Chairman and members of the committee, thank you for your consideration and for your service to the people of Wyoming.
A question? Go ahead, Representative Trujillo.
Good morning, Deacon. Do you know about Wyoming's family planning waiver program?
Mr. Chairman,
Mike, if you do.
Representative Trujillo, I do not.
I'm going to find someone eventually.
Thank you.
Other questions? The Catholic Church. Representative Penn.
Thank you, Chairman Zwanitzer. What I would ask, I have a couple of questions, if I may. Do you want me to do one at a time, or? So the first
three.
question that I have is there something about this particular program specifically that the church is supporting, or is your main focus that these women are having access to health care?
Specifically, Mr. Chairman, thank you, Representative Penn. Specifically to this, just recognizing that, again, the family is the best institution for the welfare of the mother and child. And we know that if we can take care of moms, especially when they're in that most vulnerable stage, that's good for the child. If she has other children also, that's good for them. And so that would be specific to this.
May I follow up on? Well, can I follow up on that and ask one more question? Pretty please. Thank you, Chairman. With regards to that, taking care of the family, does your church offer anything to families and mothers as far as support?
Mr. Chairman. So I do know for a fact that there are many pro-life pregnancy centers around the state that do offer some assistance with regard to other types of care, postpartum, and that many Catholics and many of our parishes do support those those programs. As far as complete access to postpartum health care, I couldn't speak to that. I don't know.
Thank you. And my final question is, you mentioned the importance of families, and I would agree with you on that. In your opinion, do you think it's the proper role of government to be involved in taking care of our families and our healthcare?
Mr. Chairman, that's a big question, Representative Penn. The state is tasked with justice, and that's a big question. A lot of times I kind of am taken aback by the pushback, that the fact that the church has somebody here speaking to questions. But the state's tasked with justice. Everybody in this room probably has a different idea what that means, what it looks like exactly. At its root, the question of justice is an ethical one. What's right and what's wrong. And religious organizations, religious communities have been thinking about that for a long time. And all of you cannot pass a law just for religious reasons, right? But it would also be unthinkable to say, well, because the Sixth Commandment prohibits death, we shouldn't have a secular law that does the same. So that is a big philosophical question. And I think our responsibility, one common thread that I hear a lot too is that the churches need to step up. That's true. But I think we also overestimate the capability of what our parishes are doing. We're not just focusing on one issue. There are many. Exactly what belongs to the role of the state. And to be honest, the state is already involved in healthcare. And then there's this drop off at 60 days. So that was way more than you asked for.
Yeah,
I'm sure.
that's a little broader than the bill, but
That's the
certainly
danger of
appreciated.
asking me questions.
Further questions? Okay, thank you, Deacon.
Thank you.
Yeah, Phyllis, or Ken. Hollis, welcome.
Good morning, Chairman, members of the committee. Dr. Hollis Hackman, I'm a psychologist from Sheridan. I represent the Wyoming Psychological Association, and we're very much in support of this bill. And briefly, we're very much in support of this bill because we know from national studies that 20% of maternal deaths are due to suicide. And we also know from national studies that the majority of those deaths, 62%, something like that, occur between day 45 and day 365. So, and as we heard from our esteemed medical provider earlier this morning, treatment for postpartum depression is available and it's effective. So we just want to make sure that it continues to be available to these mothers. So those are my brief comments. I'm happy to stand for any questions.
Do you know the standard medication regime, prognosis, length of time for postpartum depression? I think ultimately this bill, just so you know where I'm going, is we're trying to decide maybe 2 months isn't enough. 1 year certainly seems like a long time, but that is what the child is given, that 1 year. And so other states have picked a certain month. You could elucidate.
Mr. Chairman, I would defer to the medical provider that spoke earlier on this topic. I'm not a prescriber, so it's really outside of my expertise.
Go ahead, Representative Trujillo.
Do you know what the Wyoming Family Planning Waiver Program is?
Representative Trujillo, Mr. Chairman,
Yep.
I'm sorry, I do not know.
Thank you.
Any further questions? Representative Penn?
I've got it on here. I don't know what the appropriate.
Rep Penn, do you have a question? Oh, your mic's on, so just.
Oh, I apologize.
All right, seeing no further question, thanks. Before I call up anybody else, anybody who knows what the Wyoming family, Mr. Hannes, come on down, Hospital Association. Morning, Josh, welcome to House Labor.
Good morning, Mr. Chairman, members of the committee. I'm Josh Hannes with the Wyoming Hospital Association. And I know a little bit about your question. Happy to start there to move on. So that waiver program is an inability for women postpartum after they've fallen off their eligibility as a pregnant woman after those 2 months to receive some limited benefits as it relates to family planning, education, things like that. It's a limited number of services specific to family planning.
Sure, I'm sure the Hospital Association probably has more thoughts, but go ahead and questions.
I just, do you know what those limits are?
I can pull them. I have them in front of me if you give me 2 seconds.
Okay, thank you.
Or maybe, Mr. Hannes, if you, any other comments you have, and then we'll finish up with those, so that would work.
Sure, I have it right here if that's all right.
Oh,
Mr.
sure, go
Chairman.
ahead.
Yeah. So there's an annual follow-up exam, removal of contraceptive devices, necessary family planning, reproductive health, lab procedures, diagnostic tests, sterilization services, and related laboratory services, and medications required as a part of, required as a part of the procedure done for birth control purposes.
And that is a Medicaid program?
Correct.
Okay.
Follow-up?
Representative Trujillo, yeah?
And how long does this program last?
If you know.
Mr. Chairman, Representative Trujillo. I'm not sure if I can report back to you here before the end of this meeting.
I can probably find some people as well before the end of the meeting. All right, Mr. Hannes, other comments from the Hospital Association?
Certainly, thank you, Mr. Chairman. So the Wyoming Hospital Association stands in support of this bill, and we, as some of you know, but some of you are quite new, access to care is incredibly important to us. This provides that. We are supportive of a strong safety net system in Wyoming that supports residents of Wyoming. Again, hospitals are a big part of that safety net system. Hospitals in your communities are part of the safety net for healthcare. $120 million in uncompensated care that we provide to patients. So care that's not reimbursed in any way to our facilities, and that's done across the state. Patients seen on sliding fee scales, charity care. We have to insist that the safety net is supported and strong so that we can care for people. One thing I want to point out, and this has been touched on a little bit, is that this program doesn't expand the Medicaid program. It doesn't create a new category of eligibility. It takes a service being provided and coverage being provided and extends it out. And the reason that that's even an option is because what experts and providers have told us is that this is a critical time to ensure that women have health coverage. Unlike the family planning waiver, which is a useful program, it's not a comprehensive coverage. So let's say a mother just during her pregnancy is receiving prenatal care, determines she has a chronic disease, and then loses her coverage after 2 months postpartum. She can't perhaps pay for her medications. She can't see her primary care provider. And what insurance coverage does, importantly, is it drives patients to the right place of care at the right time. So a lot of uncompensated care, or to some degree, the uncompensated care we see is because people have no option to be in the proper setting of care, and they show up in our emergency rooms. And we don't get to turn patients away, and we shouldn't. They come to our facilities to receive emergency care, but that's not an appropriate setting of care for most things. And we want to make sure that people have access to be in the right place, afford their medications, and stay healthy. I want to quickly move a little bit to, there was some testimony the other day about this preventing, if you're eligible for Medicaid, not being able to go onto a commercial plan through the marketplace. That's correct. You're not eligible, well, I shouldn't say that's totally correct. You're not eligible for subsidies on the marketplace if you're eligible for Medicaid. But that doesn't prevent you from being on your employer's plan. So if you're back to work after delivering a baby and your employer offers insurance, which is how most people in Wyoming get their insurance, is from their employer, they're not at all prohibited from joining those plans. I think I'm happy to stand for questions, but I guess what I would say is that this is good policy. This is a way to help women after they've delivered a baby move into another option to move up. This is not a long-term, you get on this program and you're on forever. We want, and hospitals assist with that. We try to help people get into an environment where their care is covered in the most appropriate program. And I'll just leave it at that, Mr. Chairman, and happy to answer questions.
Okay, thanks. Representative Clausen.
Mr. Chair, could you speak, I know it wasn't your question, but somebody from the department the other day spoke about none of our neighboring states are using this program. Can you address why none of the neighboring states are using it?
Mr. Hannis, if you know.
Mr. Chairman, Representative Clauston. So I certainly can't speak for other states. What I suspect is that all of our neighboring states have fully expanded the Medicaid program, so their gap in coverage for people is much smaller. So under Medicaid expansion, you'd have coverage in the Medicaid program up to 138% of poverty. And this pregnant woman program covers up to 154%. So you'd have that 138 to 154% gap. So their environment's quite a bit different. It's worth noting too that if you fully expand Medicaid, those people are covered at 90% match from the federal government. In our program, it's a 50% match. So we're covering half the cost in our state.
Questions, Representative Hornock?
There we go. Thank you, Mr. Chairman. There was testimony last Wednesday, and I'm curious about this, but they mentioned that due to some federal law that was just recently passed, January 1st, there's kind of already coverage that extends for this program. Are you aware of that? Is there any information you have on something like that?
Mr. Hannis, if you know.
Mr. Chairman, Representative Hornock, I don't recall that testimony. I might need a little clarity if you can.
Mr. Chairman, I was hoping for a little clarity. That's what my question. It was just mentioned, so I don't know if there is somebody that can speak to that. A follow-up question real quickly. So we're talking about postpartum coverage. And currently, right now, Medicaid, a woman who has a baby is covered for 2 months. When does that coverage start?
Mr. Hannis, if you know. Otherwise, I'll probably call the department back up at some point, but you can
Sure.
field it.
Mr. Chairman, Representative Hornock, that's a good question. I think it happens once the woman determines that she's pregnant, she can apply for the program. And it begins at that time whenever it's approved by the state Medicaid program, but I'll certainly let somebody from the department give you more specifics on how that mechanically works.
Further questions for the hospitals? Seeing none. Thanks, Josh. Just to get a feel real quick, how many people are planning on testifying on this bill who haven't testified before? 1, 2, 3, 4, 5. Okay, I hate to limit testimony, but I'm gonna probably try to keep you at like 4 or 5 minutes each. So Ms. Somerville, you're closest, come on down. And then Ms. Stahl and Mr. Fuchs, you're representing the department, so maybe towards the end, just be prepared to back clean up on any of the questions that arise. Welcome, Ms. Somerville.
Thank you, Mr. Chairman. My name is Andy Somerville. I'm the Executive Director for the Wyoming Association of Mental Health and Substance Abuse Centers, more easily known as WAMSAC. We are the community mental health providers for the state, covering all 23 counties, providing outpatient mental health and substance abuse care, as well as residential outpatient and substance abuse care. Mr. Chairman, I just wanted to first say that we are in strong support of this bill. It is an access to care issue. One of the things that we see with women that are postpartum is they might come with mental health concerns, but they also have physical health concerns. That comorbidity and the importance of treating both in an integrated care is critically important to recovery. As time has gone on, we're learning more and more and more and more about that every day. A mental health condition can drive physical health issues and vice versa. I also want to touch just a little bit about capacity for mental health. I know that you've already heard some testimony about the effects and the losses of suicide in postpartum women, which are always tragic. But mental health care is not just concentrated, I think as the committee has heard, in your community mental health centers or in a counseling office. The continuum is large and vast, and we need to continue to build that out. But it's important that women be able to access that in their primary care provider's office, with their OBGYN, with a family practice physician, whatever that is, in addition to seeking counselors or coming to a mental health center, or anything along those lines. This state we certainly have an issue with access in general. We are classified as frontier by SAMHSA. And so we have to work with what we have in each of our communities. And again, we don't want to prohibit access. If at all possible, we want to encourage them to be able to see who they have in their area to provide that. Mr. Chairman, I know you guys have heard a tremendous amount of testimony, so I'm going to stop there, and I'm happy to stand for questions, but ask for favorable consideration of the bill.
Representative Trujillo.
Good morning. Do you know about the Wyoming Family Plan Waiver Program?
Mr. Chairman,
Go ahead.
Representative Trujillo, I was reading quickly in the back of the room, but no, I'm not fully versed on that yet.
Representative Trujillo, I will get the department back up to talk about it by the end. Other questions for mental health substance abuse? Representative Penn.
Thank you, Representative Zwanitzer. My question is, could you tell us a little bit about the sliding scale fee payments that are available for people who have difficulty paying for their mental health care?
Ms. Somerville.
Mr. Chairman, Representative Penn, it's a big topic, but I'll try to do a 10,000-foot view really quick. So as a community mental health center, we see people regardless of their ability to pay, and can provide that service. Currently, it doesn't matter what your issue is or your concern or what treatment you need. You can come to us and we will assess on a sliding scale fee. It usually runs up to about 200%. I think in one of our counties, it's 250% of the poverty level, and we will assign a sliding scale fee on that. And then the community mental health centers operate under state contracts that reimburse our community mental health centers the rest of the dollars for that treatment. It is worth noting that that is changing July 1st, 2024, under the behavioral health reform work that has been going on in the last couple of years. That system is moving away from an open access, all access, to a safety net system. So the state has set specific priorities for community mental health centers. So we have priority populations that we're still working on those rules, so I can't explain. I do not yet know exactly how that'll work, but we understand that it's going to be focused on the priority populations first in tier 1, and then our tier 2 is going to be what we call, it's an indigent population with serious concerns, and then tier 3 is our access. What I cannot sit here and tell you to the committee today is how that is going to work in terms of somebody actually just walking in, a mom walking in with postpartum depression. How soon we can see them, capacity and funding from the state is yet to be determined. So certainly one of our biggest concerns is mental health access in the state as we move through the reform process.
Other questions? Seeing none. Thanks,
Thank
Ms.
you.
Somerville. Whoever on this side, Ms. Decklever, come on down. We'll try to do about 3-4 minutes. Save a minute for questions. Welcome.
Thank you. Thank you, correct. Representatives, members of the committee, my name is Tony Decklever. I am a registered nurse and I represent the Wyoming Nurses Association. We are in favor of this bill because it provides for access. And that's many of the people that you've already heard, the nurses would feel the exact same way. When our moms have their babies and then babies get sick, then mom takes babies to the doctor. It could be a primary provider or it could be an OBGYN. But in many cases, it's not just the baby, but it's the entire family that gets sick. And so even though the child is covered and the parents take the child in, while they're there for the visit, it is, by the way, since I'm here, I don't feel well either. And if it's past the 60 days, then the provider, is seeing this person basically free of charge because it's just part of the well baby check or a sick baby check. The other thing that happens, and this was in testimony on Wednesday is, that these women could go back to work and they could get their employer's insurance. And that's true in some cases, but we all know that COVID really hit many of our service areas, especially for women, and one of those being daycare. In order to go back to work, these women have to put their children in daycare, and to pay for an infant care is very expensive. So the average, according to care.com, the average pay for one child for daycare is almost $200 a week. And so if you have a mom that is only making $14 or $15 an hour, and then they have to pay up to $800 a month for daycare. And we've all heard this at some point, whether it's a friend or a family member, which is, why should I go to work when all I'm doing is paying for daycare? I might as well stay home and take care of my own baby. So it's and there are programs out there that do help with daycare, but it is another kind of thing. And so if moms can stay home and take care of their children so they don't have to go to daycare. We all know that when kids go to daycare, kids get sick and then they bring it home and then they infect the entire family. And so it's just kind of this vicious cycle. That first year, it's a trying time. And for new moms, it's trying. And then if it's a second or third or fourth child, it's a very, very just intense time. There's lots of factors. And we all know that an ounce of prevention is worth a pound of cure. And so if these people have access to care and they are able to see a physician or see a provider, then it's much better than waiting for something catastrophic to happen. So again, we are in favor of this and for all the reasons that have previously been given, and I would stand for any questions.
Questions from the Nurses Association, Representative Hornock.
Thank you, Mr. Chairman. Just quickly, you mentioned daycare. If this is expanded for the 12-month period, is daycare covered under this coverage?
Representative Swanitzer, Representative Hornock, I don't believe so. Medicaid is strictly for healthcare, but if it's a choice between what I have to pay for. So if I have to work and to pay for daycare, then I don't have enough money to pay for healthcare.
Further questions? Representative Trujillo, is it a different question this time?
Nope, I want to know if you know about the Wyoming Family Waiver Program.
Representative
ahead,
Swanitzer, Representative Trujillo, I do not.
Thank you.
Okay,
All right.
seeing no further questions, thanks.
Thank you.
Department, Franz or Jan, one of you come up and talk about. Welcome back. And most of it'll just be questions, but if you would certainly answer on the Medicaid waiver program.
Good morning, Mr. Chairman. Good morning, members of the committee. Again, my name is Franz Fuchs. I'm Policy Analyst at the Department of Health. We tracked a couple questions here we can try to answer relating to the Family Planning Waiver Program, the waiver on potential timeline, less than 12-month kind of coverage, or different subset of benefits. We also touched on LARC, the long-acting reversible contraception policy. I think that was another question, and also the Maternal Mortality Review Committee. But those are the ones I've caught. I'm sure there may be more, but I'd happy to right now turn over to Jan to talk about the family planning waiver.
6 minutes or less, I'd be appreciative. Welcome, Ms. Stahl.
Thank you, Mr. Chairman. Representative Trujillo, I do know about the Pregnant by Choice program. It is a Medicaid program. It only covers benefits related to family planning, and a person can go onto that program when they finish their 60 days postpartum period, but they do not go on automatically. We send out a questionnaire to ask them to see that they want to be put onto that program. Once they go on, they do have a renewal each year. Really, it's just a short form asking them, have they had permanent sterilization or are they pregnant? If either of those are yes, then that program closes. Otherwise, they can continue that program for an indefinite period of time or until through the age of 44.
Any follow-up questions? Okay. If you go through while you're up here and any other questions the committee threw at you.
Mr. Chairman, next question was on the timelines as far as could this coverage be modified as far as the 12-month option is really the default that's offered by the federal government under what's called a state plan amendment, which is the simplest administratively to execute. And the majority of states that are doing this have chosen that option. There are a couple states, I think Texas is looking at, as the previous testimony indicated, modifying benefits or the timeline. That process has to go through, most likely through what's called an 1115 waiver. I know I don't want the fire hose of Medicaid to start now, but it's a demonstration waiver. It's administratively onerous. It takes a lot of staff effort, it takes a lot of administrative work, and there's no guarantee they get approved. CMS actually has no obligation to even respond to them in a timely fashion. So we've gone through a lot of 1115 waivers, and many times they just kind of go off into the void and we never hear back. But it is possible, in theory, to do this. And other states, I think, are pursuing that, or at least a few states are pursuing that. So it is an option, but it is just a different process.
But the response would be, we don't know how long that process could take, if ever, and this versus state plan amendment would be when the normal 60, I can't remember the timelines, but it's generally assured and already been approved as long as our state plan amendment amends to include it.
Mr. Chairman, that's correct.
Okay.
Next question was on the maternal mortality review. We have that's been brought up a couple times. We are in the process of completing that report. It's not done yet. It looked at maternal deaths from 2018 to 2020. Just a brief summary, there were 13 pregnancy-associated deaths in that time period, of which 6 were pregnancy-related. So there's kind of this necking down of kind of how directly tied it is to the pregnancy. So they really focused on those 6 deaths over that 2-year time period. And behavioral health was one of the major issues, one of the major conclusions. This was all presented at the previous joint labor, so this is not a spoiler alert per se, but 4 out of 6 were unfortunately, of those deaths were behavioral health related. And the full report will be out probably in the next month.
I don't want to assume, you mean suicide? Is that, when you say behavioral health related?
Mr. Chairman, I can't speak more to that. We have to wait till the report's out. And the final question that we are tracking here is on the long-acting reversible contraception policy, and I'm sure Jan can fill in the committee on that, as far as the ability for a woman to have a LARC implant at the postpartum visit.
Sure, Ms. Stahl, if you just quickly go over that
Okay.
process and how it relates to Medicaid.
Okay, Mr. Chairman, just very brief. We have been making some changes in that area over the last few years. We did make a change on January 1st for 2022, where hospitals were able to bill for LARC insertion at the time, but they did have to bill that on a separate form. They had to do it separately from the bundled payment.
Any questions for the department while I have them back? Representative Penn.
Thank you. So because I know that some here weren't here on Wednesday, to confirm, and if we're not, with this program, we're not talking about at the end of 60 days, all women losing coverage. We're talking about women, because currently they would still qualify at 100 for regular Medicaid at 100% of the federal poverty level, but the postpartum coverage that we're discussing is actually increased to 154% of the poverty level. So they potentially could still be eligible for regular Medicaid after the 60 days.
Ms. Stahl.
Mr. Chairman, Representative Penn, yes and no. So we do not have a program that covers a woman up to 100% after she has given birth. We have a family care program for families who have minor children in the home, but it has a much lower income level than 100% of the FPL. But we do review a pregnant woman when she's about to lose coverage for any other program that she might be eligible for. So if she did qualify for family care, we would put her on that program. If she didn't, we would give her that option to go on to that family planning waiver, but it only covers services related to family planning.
I probably need to ask the dumbest question I've asked in a while. So immediately upon birth, does that federal poverty level change with the number of children? And is that an immediate, is that you have to wait 60 days, you give birth to twins, and all of a sudden your FPL level goes haywire? How does that work?
Mr. Chairman, actually, when a pregnant woman applies for benefits, we actually count that is actually a two-person household. Because from the time they apply, and there is a child, the person is pregnant, we do count that. If at the time of birth, she instantly continues that two-person or three, whatever her household size is.
Other questions for the department? Seeing none, you do have one, President Hornock, okay.
I do. Thank you, Mr. Chairman. By the way, this is actually fascinating testimony, so thank you for, I know it's going long, but yeah, okay. I look forward to it then. Director, I'm wondering what is covered? We're extending coverage. We're talking about Medicaid coverage. What is covered? Are we talking about the gamut of a woman breaks her leg during that 2 months or at the 10-month place? Is that covered? What specific coverage are we really discussing? We kind of had that question between us earlier, so I'm looking for that.
Mr. Chairman, Representative Hornock, it is the full Medicaid gamut. If a woman, and that includes the time when the woman is pregnant. So during the pregnancy, the postpartum care, and it would continue on to 12 months if this were to pass. If she falls and breaks her leg, yes, that's covered. If she needs behavioral health services, it's covered. If she needs to be hospitalized again, yes, that is covered. Any medication. So it is the full gamut. The only thing that she would not qualify for is things like nursing home placement without meeting other requirements or waiver services.
For the questions, all right, seeing none, thanks for coming back up. We did run a little long, but if anybody feels compelled to add something that hasn't been added, go ahead, come on. You can just sit up here next to Lindsay, she's very friendly. We can fill all 3 seats, save some time. Mr. McNiven, you're gonna testify as well? Okay, Travis will be on deck. Go ahead, Lindsay.
Mr. Chairman, members of the committee, my name is Lindsay Simoneau, and I represent the Wyoming Counseling Association. I will be brief, and my goal is to also be helpful with answering some questions. I don't want to repeat anything. We are in support of this bill, echoing my colleagues. A few things that have not been addressed. As far as the U.S. maternal mortality rate being one of the highest among developed nations, I was able to pull that up. It's among 11 developed nations. The other countries are France, Canada, the UK, Australia, Switzerland, Sweden, Germany, the Netherlands, Norway, and New Zealand. And so just to give you guys the perspective of that. And to save all of us some time, I am aware of the family planning waiver. And though it is a fantastic support program, we do recognize that there are limitations within it. The first being the fact that women are going to have to apply 45 days before their Medicaid coverage runs out. I, as a woman who has given birth to 2 children and had a supportive partner and double income and my family living in the same city as me, I wasn't able to find pants 15 days after delivering birth or delivering a baby. And so the idea of these mothers having to apply, it is an obstacle. What this program is able to do is not only extend coverage for mothers, but do it seamlessly, that these new moms postpartum will not have to fill out new paperwork in order to be transitioned into this program, which really does only cover reproductive health. It will not cover any behavioral health benefits. And for us, we're really looking at that postpartum depression and supporting those mothers in those first 12 months. So with that, I stand for questions, and I think that's the fastest I can do that.
I like it. Questions for Counseling Association? Seeing none. Thanks, Lindsay. Welcome to Labor Health. Floor is yours.
Thank you, Mr. Chairman. My name is Rebecca Hazelton. I am the director of the Wyoming Women's Foundation. We're a fund of the Wyoming Community Foundation. We are a statewide nonprofit, and our mission is to help women achieve economic self-sufficiency and provide opportunities for girls. My colleague Marissa Carpio is here with me today to help answer any questions you may have for us. I'll just start off by saying that the Department of Health presented at one of the interim committee meetings, for those of you who were not there, that 1 in 5 women lose insurance 3 months after birth. So just to kind of build on what the previous testifier said, there's a loss of, with the 60-day limit, there's a loss of insurance. And part of the reason for that is because of the limited options. I am aware of the waiver that has been brought up many times, but I would echo the previous testifiers that that doesn't provide comprehensive care, and that moms need that in order to go back to work. So we would like to see that moms are in a position where they can go back to work and that they're healthy, so that they can contribute to their communities and to their to keep their children in a self-sufficient position. I just wanted to mention too that Medicaid moms are more likely to have chronic conditions, preterm births, and low birth weight births. So for those that do transition off Medicaid after 60 days, there are a couple of options mentioned on the Department of Health website. One of them is to get on a partner's plan, insurance plan. And we know that about a third of moms are unmarried that are giving birth, according to the Wyoming Kids Count data. And so that means they probably don't have access to a partner's healthcare. Another option, of course, is to get employer-sponsored healthcare. Many of moms that are low income are working jobs in retail or food service or at daycare where they're not, they don't have insurance available to them. So I would also point to a resource that's available on our website, the Wyoming Women's Foundation website. It's called the Self-Sufficiency Calculator. And you can look at that to see what the costs are estimated for a family. For instance, you can select a one single parent with an infant and see what the monthly costs are. And I would echo what one of the previous testifiers said, that childcare costs are extremely high. And then healthcare costs also. So for instance, for a mom and an infant in Albany County, healthcare costs come in at about $500, as well as that childcare between $700 and $800. So anything that we can do to provide a bridge to moms to return to work and to become self-sufficient is something that we support, and we ask for your support of this bill.
Okay. Question or anything to add? Just checking. Questions for the Women's Foundation? Seeing none. Thanks for being here.
Thank you.
All right, Mr. McNiven, anybody else need to provide public comment on something we haven't heard? If not, we'll let you wrap it up, Travis, and then I'll probably have either Franz or Stefan get kind of close to the front because I'm sure we'll have questions after. Go ahead, Travis.
Thank you, Mr. Chairman. My name is Travis McNiven, today here on behalf of the Northern Arapaho Business Council. And with the sake of time and to not belabor any of the points that have already been taken on the importance of access to benefits, I will just note that there is a real need among tribal members and populations. As the deacon pointed out earlier, oftentimes it is hard to get women to go to the hospital. They're tough, don't want to, or there is a belief that if they go, there will not be the access, provided or turned away. That stems to a certain extent from the Indian Health Service, does assist in funding tribes to provide healthcare to tribal members, but that that funding is often insufficient to cover the needs. So postpartum benefits such as this to assist the tribe's healthcare would assist the tribe's healthcare facilities with covering the cost of providing postpartum medical care for women for that additional 10 months would be a very helpful and useful thing for that population within the tribal members and the communities there in central Wyoming. Thank you, Mr. Chairman.
Thank
Happy
you.
to answer any questions.
Questions? Representative Penn, I was guessing you might have one. Go ahead.
Thank you, Chairman. Mr. McNiven, my question is about the coverage that the Northern Arapaho members have with IHS, Indian Health Services, and how that overlaps with Medicaid coverage.
Mr.
Could you speak to
McNiven,
that?
if you know.
Thank you, Mr. Chairman. Representative Penn, I will share what I do know, and that is this. There's Northern Arapaho actually has what's called a 638 contract with Indian Health Services, and the Eastern Shoshone is a direct service tribe. So there's a slightly different mechanism in place where Wind River Cares receives kind of like a lump sum, and I may be oversimplifying that, kind of like a block grant from Indian Health Services, and then they control their own decision making. Again, I apologize if I'm oversimplifying that. Eastern Shoshone is more of what is called a direct service tribe. How that interplay with that interacts with the Medicaid, I do not know the specifics to that. Would be happy to get additional information for you on that and how that role works.
Okay, other questions? Thanks, Travis.
Thank you, Mr. Chairman.
All right, with that, let me just double check the Zoom room. We'll close public comment. Committee, this is a point where we ask if anybody wants to move the bill, so I would entertain any motions on House Bill 4 at this time. Moved by Representative O'Hearn. Is there a second? Second. Seconded by Representative Chadwick. So committee will go through the bill. It's not very lengthy, but if there are any amendments. Director Johansson, did I see you walk in? Could I come on down? I just have a question. LSO Fiscal, as they were going through this legislation, did notice that we may have over appropriated the amount on a 2-year cycle, and you're only requesting 1 year of funding through the end of the biennium. I just want to check with you to see if that was brought to your attention, because they did provide us an amendment with my name on it to cut the funding down to 1.9, and just making sure that was run across your desk.
Mr. Chairman, members of the committee, Stephen Johansson with the Department of Health. Sorry for my tardiness. I was hurry up and waiting with JAC, who canceled their meeting this morning. Let me get with my team, Chairman, on that amount. I think that would be okay. As you know, the bill has some language in it that does not include this in our standard budget. So there is that differentiation between fiscal year and biennial amount. But I'll get with my team quickly, and if there's an issue, we will let you know.
Okay, I'm probably going to push it, and if there is, let me know, and if the bill passes. With that committee, as your chairman, I can't actually bring the amendment, but LSO has prepared an amendment with my name on it to cut the funding down to half of what's contemplated in the bill. If anyone would like to move that at this time, Representative Yin.
Mr. Chairman, I'll move the amendment.
Is there a second by? I'm going to like having both of you next to me this meeting. Seconded by Representative Chadwick. And so committee, what this does, if you look at the fiscal note on the back of the bill and the appropriation contained in the bill, LSO believes that based on the fiscal year cycle, they only need the 1.9 million. Again, that would be matched by the federal funds to get them through to the next biennium, where if this bill passes, they would go before appropriations, and perhaps this committee again, and we'll determine, I think, based on more statistics, if the program has been beneficial. Is there any comment on the amendment? Representative Hornock.
Thank you, Mr. Chairman. A couple questions, I guess, on this. We're talking about this amendment. Will this amendment be capped at $1.9 million in the future, or per the bill, they're allowed to request appropriations next time around? Is that will that appropriation be based on this 1.9? Will it be based on statistics? Will it increase?
From my understanding, Representative Hornock, and I'll be corrected if I'm wrong, they'll look at the program here in a year, and if that number is above or below, they would revise that estimate. This 1250 is based on the current number of people who are applying for Medicaid. Would that be correct, Director Johansson?
Mr. Chairman, yes, and Representative Hornock, to answer the previous question, did confirm the amendment. There's no issues with that. Two things going on here. One would be if there is a change in utilization or enrollment that is either below or above our projections, we would certainly work with the legislature next session to make those changes. The second thing, more on the mechanical side, is if funding is not included in the standard budget, then it's just one fiscal year of funding, and we would come back if the program is authorized to continue to request it in our standard budget in next year's session. So essentially what that would look like, if we assume that our enrollment and cost projections are accurate, those biennial figures would be added to our standard budget. We can't obviously spend funding that you all don't appropriate, so we wouldn't have the authority to do that.
Any other questions? All right. Oh, yep, Representative Hornock.
Well, I'm not sure if this is a question or a comment on it. So, you know, the balance of spending state funds for what we're looking at here. We heard in testimony and that was a big question for me, is what is exactly covered? And it seems like the full gamut of Medicaid coverage would be available to these women. I have a little bit of a hiccup, not that I like spending state money, but I have a little bit of a hiccup throwing a low dollar amount in here. Just because if appropriations have to come up later, it doesn't seem like then we go through this process again. I would kind of lean towards making sure we've got the money, if this bill passes, to fund this program. I mean, if we have a situation where somebody needs additional health care, for instance, my sister has a 9-month-old. She broke her ankle soon after birth, and then over Christmas, she has been in the hospital since Christmas, actually, with bacterial meningitis in intensive care. It has been a huge stress on the family, not knowing if there is brain damage. We know there's hearing loss. All of a sudden, it was an immediate, where she wasn't able to nurse her baby anymore. It was a big deal. That would be covered. We're talking a lot of money for that service, and per the fiscal note, we're talking about per member per month $250. In the original fiscal note, that would be reduced by half if we approve this amendment. So anyway, it just seems like it'd be tight.
Sure, go ahead, Representative Yen.
Mr. Chairman, thank you. So I believe the intent of the amendment is just to make it cover the fiscal year 2023. Because we're in the middle of a biennial budget, the Department of Health will still have to go to appropriations again in the following year with the governor's rec for the next biennial budget, which will start in 2024. So the 1.9 million will still cover 2023 according to the estimates in the fiscal note fully. And even no matter what, if we enable this program, Department of Health will still have to fully cover Medicaid for those women within their currently allocated budget. So there will be no half. I believe that was in the testimony Director Johansson gave on Wednesday. They don't get like a half provision of the Medicaid payment. It's just it's fully enabled, and those benefits have to be paid out by the state. And so in 2024, if the program is still enabled and the Department of Health still needs funds, they will go in front of appropriations for our next full biennial budget to ask for more funds to make sure the program stays funded.
And I believe that's correct, Director. If it's above that number, you find the funds internally and cover that.
Mr. Chairman, that's right. As I mentioned on Wednesday, it's always an interesting dynamic. We give you estimates on what we think on average for the whole population things will cost, and we're really comfortable with those numbers. When we see changes in populations or utilization in a fiscal year, let's say, we don't have the ability in Medicaid to cut payments, so to speak. Those are, if the person receives the service, we pay the rate, we pay the reimbursement to the provider. But if we see big changes in utilization or enrollment, then we always come back to the legislature to make adjustments, whether it's up or down.
Further questions on the amendment? Representative Penn? Representative Hornock?
Well,
Light's
just
still on, so I thought I'd check.
Thank you, Mr. Chairman. Just a comment, and I would be sort of against the amendment. If the health department has to find the funds out of their own budget, it seems like, why don't we just try to fund the program? That's kind of my thoughts. Thanks.
I'm hoping somewhere in that $1.8 billion, if this exceeds, you might be able to locate it.
Mr. Chairman, just over $2 billion as a correction. So Mr. Chairman and Representative Hornock, I appreciate the concern and the sensitivity to that. Again, on the mechanical side with this appropriation and with this amendment, I think we're okay. Given that there's language in the bill that specifies right now it's not in our standard budget. If that language were removed, that it would be included in our standard budget, then the amount would what we call biennialize. So essentially it would take it up to what the fiscal note said. So I will say, Representative, I'm comfortable with the amendment. This will take some time to get a state plan amendment approved. And once if this were to pass, once we launched the coverage extension, we would monitor that over the first 5 or 6 months of operations and come back to this committee and appropriations with any changes.
Okay. Discussion on the amendment. Representative Ward.
I'm going to be a no on both. Probably not a surprise to my committee members. That's because the pandemic, which is now over, is being used as a justification for expanding Medicaid in the sense that it expands coverage by 9 to 10 months for the mother. Babies are already covered, and the mother is already covered by other programs, as we have seen. An entitlement program, which is not the role of government, once it is expanded, is nearly never contracted. So I'm going to be a no, whether it's 1.9 or 3.8. And furthermore, I would like to address the commenters who are using pro-life as
You're on the amendment. Then we'll have open discussion after the amendment
Okay.
before the bill, if that works.
Thank you.
Yep. Any other discussion on the amendment? Seeing none, question on the amendment. All in favor of the proposed amendment number 1, please say aye.
Aye.
Opposed, say no.
No.
Okay, that amendment is passed. Feels good to cut $2 million once in a while. Are there other amendments on the bill? Before I ask for discussion, I'll ask for amendments. I don't know, Representative Ward, you might have one on page 2, line 5 you mentioned in the comments. If you would like to change that language, certainly would allow you to bring that amendment.
What's page 2, line 5? Yeah, yes. I would like to change a person to a pregnant woman, since we all agree that only women can be pregnant.
And because it says pregnant, yeah, just person to woman would probably be the amendment. Seconded by Representative O'Hearn. Discussion on that amendment? I don't think it hurts anything in the bill or in our statutes anywhere else. So all in favor of that amendment, say aye.
Aye.
All right, we're 2 for 2. All right, any other amendments on the bill? Before we take the vote, any discussion any member of the committee would like to offer before their vote? Would entertain so at this time. Representative Ward, if you had more.
Yeah, in addition to what I've already said, arguing that if you're pro-life, you have to be for the expansion of entitlement programs does not follow. Cain commented to God, "Am I my brother's keeper?" The obvious answer is no. No, I'm not my brother's keeper, but just don't kill him. So I will be a no on these. Thank you.
We'll just go down the line. Representative Clauston, if you have.
I think this is a big enough issue. We've covered it for 2 days and hundreds of emails that I think this needs to be settled on the floor. I appreciate everybody's input, and I'm going to vote yes, just so we can discuss it on the floor. Thank you.
Representative Trujillo, anything?
Yes, through you, Chair. Thank you. So I'm going to be a no vote on this. The title of this bill is Medicaid 12-month postpartum coverage. And as I've asked many people today about Women's Family Planning Waiver Program, which is a postpartum program for women. That's our intent on the bill, is to take care of the women's rights. I'm going to give you guys just a little bit of information. It says limited reproductive health benefits under the Pregnant Choice Program covers education about reproductive health, methods of birth control, initial physical exam, health history, including pap smears and testing for sexually transmitted diseases, contraceptive management, including prescriptions, devices, and supplies. It also goes to the State of Wyoming Pregnant by Choice Family Planning Waiver Program. Annual follow-up exam for reproductive health and family planning purposes, including pap smears, testing, and follow-up for related family planning. It also is for removal of contraceptive devices, necessary family planning, reproductive health, laboratory procedures, and diagnostic testing, and it also provides sterilization services and related laboratory services and medications required as part of the procedure done for birth control purposes. With this program in Wyoming and the title of Medicaid 12 months postpartum coverage, I'm going to have to be a no.
Representative Chadwick, anything?
Thank you, Mr. Chairman. You know, I find that what the providers have told us and their willingness to take on this burden, this financial burden, I find that compelling. They believe these are the people. Yes, that's their job, is to help people. But I find that stance by the very medical community and virtually every aspect of it, you know, hospitals, doctors, psychiatric, they're all in line. They all believe that this is necessary. I'm going to have to support it. Thank you.
And again, committees, there's no, you know, pressure for you to speak. It's just an open opportunity, you know, because the press and your constituents are here. So if you do want to say anything, you're welcome to. Representative Yen, we'll just.
I'm good, thank
Okay.
you.
Representative Ahern.
Thank you, Mr. Chairman. I was a strong yes on this 2 days ago. At the end of the discussion on Wednesday morning, I was wavering because of some of the comments. Found out some of those were misleading, and now I'm a strong yes. And like Ken says, I want this to go to the floor with both houses.
Representative Penn?
Yes, please. Sure. So first of all, I just would like to, I guess, congratulate everyone here, because this has been a difficult discussion. It's one that comes with a lot of emotion, and I appreciate the opportunity to be able to come together and have the discussion and be kind to each other. And so, you know, thank you all for that. I have some concerns about this bill. You know, it seeks to do a good thing. My concerns are that, one, we've heard a lot of testimony, and we've talked about a lot of potential complications and things with postpartum. I stand to come under fire if I vote no against this, saying I'm not for women. I'm for women. I am a woman. I have children. I've been pregnant without insurance before. We've, again, discussed a lot of weaknesses with women, but I know that women are strong. You know, there was the allusion to a postpartum woman is going to be too overwhelmed to be able to fill out a form to look for other opportunities, to see if there's coverage available other places. If we create situations where there's always a safety net, where women don't have to stand up and be strong to show their strength, then the natural man in all of us falls back into that comfort and that safety net. On Wednesday, there was Director Johansson said that we had the perfect opportunity when we were where we were not allowed to disenroll people from Medicaid because we had accepted that 6.2% financial incentive. So he said that we had an opportunity to take a look, to kind of study what would happen if we did choose to extend this. And what he said really hit me. He said that while we had that perfect opportunity to study this before we set it into place, he said that we can't say for sure if this extension has offered us any increased efficiencies, if it has saved money, if it has decreased deaths, if it has decreased emergency room visits. So we've sat here today and we've talked about, well, we have a possibility that a woman could develop a heart issue after delivering her baby. We have a possibility of this, and admittedly, those things were rare. But when the actual study, as well as we could do the study in this particular situation, was done, the benefits were not identified as being substantial in my mind. My greatest concern here is that extending, I understand this is not an expansion, extending a federal program just further ties us to the federal government. that I just described with the federal government saying, okay, we're going to give you 6.2% increased payment. And one of the strings attached to that is now you're no longer allowed to disenroll members. And we didn't have an end date on that. We do now, but we didn't, and it's been a couple of years. And so when we started that, the testimony was that our enrollment at that time was about 1,500 members. During that time, it went up to 4,200 members. So you can see what can happen, the potential for having those federal ties. We no longer have say in how we run our state and how we have our health care. We heard testimony today about how, well, you know, we would like to be able to do this. We would like to be able to provide a woman with prolonged birth control at her 6-week postpartum check, but Medicaid won't let us. As a person in healthcare that deals with Medicaid, that term, Medicaid won't let us. We hear it too much. When they're paying for it, they control what we get to do as providers. And it's not okay. It's not good. The more that we allow the more that we look to the federal government for a solution to a problem, the less opportunity we have to allow the free market to step up and address that problem. And so this extension is just one more way that we've removed an opportunity for free market to step and help. And free market truly is the best way to go about it. That's how costs come down. Looking to the federal government is how costs go up. And that's not what we want for our state either. As legislators, we have difficult decisions to make, and oftentimes they're unpopular decisions. But I always want to make sure that I'm a responsible steward of taxpayer monies. And with regard to federal involvement, in my opinion, it encroaches upon our liberties for those reasons that I just discussed. And liberty, once lost, potentially is lost forever. It's a difficult thing to get back. And for those reasons, I would urge a no vote.
Thanks. Representative Hornock, anything?
Thank you, Mr. Chairman. So this is very interesting because it obviously deals with the most precious and the most beautiful among us. You know, the mother taking care of an infant. So it is a precious time for those mothers, for families, for individuals, for the baby. And I understand the idea that we want to create some safety nets for those individuals. However, for me, you know, I'd like to, prior to the pandemic, we didn't have this system in place. This system came about during the pandemic. And so it's my opinion that the pandemic is over. And we heard some testimony that it was, they were trying to figure out ways to unwind, I think the term was. And so I don't think the pandemic world is the world that I want to continue living in. I'd like to go back to, as much as possible, the way we've kind of had it. I thought it was very interesting during testimony that the Medicaid coverage that we're talking about to the certain women, to the individuals, begins at pregnancy. And just on a side note, so the federal government, when does the federal government determine that baby's life? Is it at conception? Is it at a heartbeat? Is it at 28 weeks? What does the federal government consider? Just a side note there, but just an interesting part of testimony. But anyway, I'm going to be a no vote on this just because I'd like to unwind from the pandemic as that term was used.
All right, seeing no further discussion, Representative Ward, do you have
One
something
more
else?
sentence.
One more,
And
sure.
the vast majority of people who emailed me about this urge a no vote. We the people of Wyoming do not want this.
With that, Marilyn, if you'd call the roll on House Bill 4.
Representative Chadwick. Aye. Representative Klauston.
Aye.
Representative Hornock.
No.
Representative O'Hearn.
Aye.
Representative Penn.
No.
Representative Trujillo.
No.
Representative Ward.
No.
Representative Yin.
Aye.
Chairman Zwanitzer.
Aye. And if you'd read the vote back.
Yes, sir. The vote for, 5 ayes and 4 noes.
Thanks. So House Bill 4 will go to the floor. Representative Yin, you're welcome to carry it, or I can, as it's the only committee bill we've had so far. Just for some housekeeping things, we are going to hear we're not going to hear anything else today. I apologize to those of you who stayed with us to not get to our 2 tribal bills. We are going to hear House Bill 81 first on Monday. It was a committee bill that's been kind of redrafted by Representative Larson to take care of some appropriations issues we've been dealing with. And so House Bill 81 will be our first bill up on Monday, followed by House Bill 18 and House Bill 19, if time. With that, we are adjourned for the day.